Hello, colleagues. A very warm water welcome to our webinar. Oh no, hang on. We don't want warm water, do we? We want hot water, not just warm water. Anyway, welcome to the webinar. We're delighted to have Dr. Jessica Martin join us today to talk about how to tackle water hygiene risks in hospitals. We're delighted that you've been able to find the time to join us. We know everybody's incredibly busy. Hello, Jessica.
Hi, good afternoon. Hi.
And hi, Phil.
Hi, John. Hi, Jessica. Great to have you on.
So I thought I'd just throw a quick question around before we get started to get us in the mindset for water hygiene. So, Jessica, there is a lot not to like about water hygiene in many ways, but what do you love about it?
I think it's really interesting, John, and I think one of the real privileges of being an infection control team member is to work with everybody across the entire organisation in a hospital. And as you get to know your estates and engineering colleagues through learning about water hygiene risks, you get to learn a huge amount and often have little tours of secret back parts of the hospital that you wouldn't usually get into in terms of ventilation and water and rooms, etc. So yeah, I really enjoy the learning and the tour of the site. That's what I enjoy. I don't know about you, Phil. What do you like?
That's a really, I think the multidisciplinary element of it and how you have to involve and bring all those other stakeholders with you. I like it because I'm a bit of a geeky microbiologist and I like getting into the different microorganisms, and I think it's always really interesting to hear about some of the infections transmitted by water that we don't maybe normally associate with typical healthcare. So the diversity and the complexity of it, although they're a challenge, I think it's kind of really interesting from a micro perspective. And what about you, John?
Yeah, I mean, I like getting into the plant room, as you can see behind me. It's just a fascinating world within a world. It's a bit like the sewer system under a big city. It's a fascinating back world that we've all getting to know and love. Okay, fantastic. So let's make a start. So just by way of introduction, really, we're aiming with these Insight webinars in partnership with the Healthcare Infection Society and the Infection Prevention Society, along with IPC Partners, to provide a bit of a kind of expert overview update on a relevant topic. Today it's water hygiene, but there's other topics throughout the year. We're keen to generate discussion. So it's a big webinar today, quite a big audience. So we're expecting quite a lot of questions. Do please get your questions in as Jessica is talking to us rather than at the end. It will help us to sort of filter through and pick the ones we think would be most useful to ask. Do also use the upvoting feature on the questions that you ask. So pop your questions into the Q&A and general comments into the comments tab, please. Keen to provide opportunities for CPD. This event is accredited for one CPD point by the Royal College of Pathologists. We want to exercise critical thinking. We don't take things at face value in this forum. We really want to understand what's going underneath the bonnet, and in doing so try and build confidence for your own independent research and study. We are keen to foster a network of enthusiasts and, of course, to have a little bit of fun. So with that, I will stop sharing and I will hand over to Jessica to tell us about how to tackle water hygiene risk in hospitals.
Thank you, John. Can I check you can hear me okay, John?
Yes, loud and clear.
That's great. Okay. So yeah, thank you so much for joining today. My name's Jessica Martin. I'm a consultant microbiologist. I'm the medical lead for infection prevention in Leeds teaching hospitals. And I'm also the chair of a special interest group that's been commissioned by the Healthcare Infection Society with a focus on antimicrobial resistance and wastewater. And as John says, my title today is how to tackle water hygiene risks in healthcare settings. Okay, my slide will move on. Good. So I'm really worried that many of you have joined, and there's many of you that have joined because you think I've got all of the answers. And I have to say right at the outset that I do not have the answers. We've got a strong recognition of the risks of pathogens from water and wastewater. And with that recognition have come many questions. And speaking to John before the webinar, what he and I feel is most useful to share really is the principles and practice of how you approach this in a larger organisation. Having recognised and believed those risks, how do you work together with your colleagues to address, risk assess and control the risks as best we can, given what we know at the moment? So to do that, we will be looking at principles and practice of controlling hygiene risks, looking at emerging risks as well as those that we are already familiar with, looking at the leadership and governance, training and education. What's the difference between responding to an outbreak or perhaps being more proactive in your work? Looking at some of the changes to clinical practice that you can make and looking at some of the changes you might want to make to the built environment. And to give you an understanding of my background, we recognised the risk from water and wastewater in Leeds in 2020 and did a lot of work at that time and have continued that work over the last 5 to 6 years. We've learned a huge amount from each other and we've learned a huge amount from working with many partner organisations and other trusts. And that's what we'll bring together for the next half an hour or so as I sort of walk you through. So I thought it'd be quite nice to start with some familiar territory. And I don't know if anybody on the call is actually estates and engineering trained, but hopefully this is where many of our water safety groups would start their work. And that's with the HTM, which is obviously our guidance document in the UK about maintaining safe water in healthcare premises. There's a number of pathogens mentioned in the HTM, but really the recommendations are centered around 2 pathogens. One is Legionella, which is a pathogen that we tend to worry about is in the water distribution system. This is still a very relevant infection. You know, we still see 472 cases a year, of which 4 or 5% are healthcare associated. And if you look at the UK HSA data, there's between 9 and 12 outbreaks related to healthcare from Legionella each year. So we absolutely need to make sure that we are maintaining water safety from a Legionella perspective, as we also adopt new learning and new interventions. Similarly, Pseudomonas aeruginosa is a real focus in the HTM and obviously has its own supplement in terms of controlling those risks. And many of you will know that that followed the report from the Belfast outbreak in the neonatal unit in 2012. Pseudomonas aeruginosa is different from Legionella in the fact that it's got a bidirectional relationship with the water and wastewater system. So staff and patients might contaminate water and wastewater with Pseudomonas, or they might acquire Pseudomonas from the water or wastewater system. And so it's a little bit more complicated to understand how important it is in healthcare associated infection. And for instance, if there's 4,500 bacteremias related to Pseudomonas aeruginosa in England and Wales each year, we don't really understand truly how many of those might be related to the built environment. But certainly, I think it's really important as we learn more about water and wastewater to maintain really robust control measures for both of these pathogens. And many of our estates and engineering, IPC and microbiology colleagues are really familiar with those control measures. This is about the safe design, build, commissioning of buildings. It's about maintaining them safely, removing dead legs, looking at temperature controls, and some people use biocides. And obviously we do a lot of water sampling as well to maintain assurance around these pathogens. It's all very important work, but it is what I would call familiar territory in terms of hygiene risks. But what we then come to is maybe less familiar territory, or certainly less comfortable scenarios, of which there's been a number in the newspapers here in the UK. And I know that this is not unique to the UK, it's happening elsewhere across the globe as well. One of the most high profile cases has been in the Queen Elizabeth Hospital in Glasgow. There was a statement released in January as they started to close the inquiry to that outbreak of infection, where the Health Board acknowledged that there was a causal connection between infections suffered by patients and the hospital environment, in particular the water system. This is absolutely not unique to that hospital. There has been a number of concerns around water and acquisition of infection, particularly in immunocompromised patients, but actually in other patient groups at times as well. And in response to one of those outbreaks, we had a new document in August 2024, which is our estate's technical bulletin, really recognising the risk from the built environment and looking at some of the mitigations we can put in place to control those risks. But this is different, I think, to that standard water safety group work about Legionella Pseudomonas. This is much more complex work and much more far-reaching. And I think the thing that's really sort of burgeoned the interest potentially as well with water and wastewater is the many, many, many publications around outbreaks of infection, particularly antimicrobial resistant infection related to water and wastewater. This is looking at ESBLs, CPEs, and originally there was a small number of publications, and these go back a good 20 or 30 years. But there's been an absolute mushrooming in publications recently, and I could spend the next half an hour just talking about those that have come across in the last week. And what you get from reading the many outbreak reports is the story coming through very clearly that these are stealthy outbreaks. They're difficult to control with standard infection prevention interventions. They're very diverse in terms of their genomics, in terms of their pathogens, and in terms of the harm that they cause patients. So there's a huge amount for us all to understand. And this is across the globe. Again, there's a lot of publications in the last couple of years from lower middle income countries who've, again, you know, very much recognized these risks and put lots of really fantastic innovations into controlling them. So we've got our comfortable zone of Legionella and Pseudomonas. We've got our hospital concerns around environmental risks. We've got our wastewater conversation about antimicrobial resistance. And then we've got the day-to-day reporting of things like blockages, leaks and floods in complex hospital buildings with very complex pipework and water systems. And again, this is taken from national news. On the right, you can see there the sort of costs of maintaining the NHS estate here in the UK. And again, there's been certain high-profile floods and flooding events. And we know that the egress of water into clinical areas is a risk, particularly given what we know about the contents of wastewater in terms of the pathogens. In terms of what causes the blockages, floods and leaks, well, we do cite ageing infrastructure, but there is also something that needs to be said, and needs to be said very clearly, about things being down drains that shouldn't be there. And you can see there at the bottom some wipes that is blocking some pipe work. Some of the really interesting work that is coming through is really trying to tease out the interrelationship between our human microbiome, so the infections that we're seeing in our patients, or the colonization risk in our patients for things like CPE, and our hospital microbiome, so those samples that are taken from wastewater of hospital environments and how they may interrelate. And this is a really beautiful study that was a systematic review actually that was published by Nicole Sturser from the Oxford team, and they've done loads of wonderful publications in this topic area. And what they were able to show, looking at 33 studies that were global, was concordance between the wastewater taken from hospital settings and the clinical samples for the patients cared for in those hospitals. There were some caveats to the quality of some of the data, and there were certainly some species and settings where concordance was stronger than others. But it starts to tell this story that we need to look after the built environment that we're working within, particularly the water and wastewater environment, in order to protect our patients from AMR. And there's been some really interesting developments in this area, and it's one of those parts of medicine that I think has been so fascinating to see it develop, because it makes such perfect good sense, and infection control is very much about good sense. And what we've seen really is that we know there will be biofilm in the water and wastewater, but particularly in the wastewater pipes, this is a sort of P-trap under a sink, and many of you will be familiar with this concept. And we're feeding that with some opportunistic premise plumbing pathogens that will be coming through the water system anyway. We're feeding it with some microbes from staff and patients, and then a bit of food and drink as people tip their cup of tea away. And into that, we might be putting some antimicrobial selection pressure by either incorrect disposal of antimicrobials or through antimicrobial excretion from patient waste. And this publication cited at the top right there from 2019 really describes the ability to detect antimicrobial residues, sometimes at therapeutic levels, in wastewater in healthcare settings. So we're providing a beautiful, warm, nourishing environment to develop antimicrobial resistant pathogens. So we started off talking about Legionella and Pseudomonas and really the water distribution system, so the pipes that are taking water from around the hospital and out to the taps and showers and baths around. And what we've now ended up with is a really complex picture of multiple pathogens, and not just the water distribution system, but also to be considering the retrograde risks from the wastewater system back into the clinical environment, and also to starting to think about human behaviour at the periphery of the water system, as Mike Weinbrain calls it, which is kind of, in and around sinks and showers. And it's really difficult then, as a water safety team in a hospital, whoever that may comprise, to get your head around that and make sure that you're turning and facing the risks and putting in the correct mitigations with the knowledge that we have at the current time. And it's really interesting as people are publishing more studies looking at the microbial story behind this. There's a nice study by Healy that was published in the Journal of Hospital Infection, which really described that there's going to be some overlap, but there will be some subtle differences in the pathogens. So you might be more likely to find mycobacterial pathogens from water, more Pseudomonas from wastewater, and maybe more human pathogens, staph and streps and things from the sink surfaces. And the interventions to each of those pathogens need to be bespoke. I think there's a huge amount of interest in what the solutions are to the risks. I think the risks are now well recognised. But I think it's useful before we go into what they might be and different ways of practicing to think about what we do agree about as an infection community. And I've spoken to many people, certainly both across the UK and outside the UK. I think we do now all agree that water and wastewater are significant patient safety concerns, and that water pathogens, as we saw them, Legionella Pseudomonas, now need to also include our traditional gram-negative Enterobacteriales, Klebsiella, E. coli. And there's actually some recent publications even looking at things like Candida auris in wastewater. So we need to broaden the scope of what we see as a water pathogen. I think it's really important as infection prevention and control teams to recognise the different epidemiology of outbreaks and risks related to water and wastewater, that we are very much framed, certainly in the UK, I haven't worked outside the UK, in a patient-to-patient transmission time frame, by which I mean we're looking for 2 pathogens to occur in the same ward within 28 days in a patient group. And actually our built environment and our water and wastewater environment hasn't read that rule book. And these outbreaks and infections can be very stealthy, happening over a very long period of time. I think there's good agreement about the fact that these risks can be in new and old buildings, but actually we also know that we need to protect future builds, and that future protection of new buildings requires a lot of IPC expertise, project water safety groups, avoiding of wet testing, and very careful construction and commissioning of new buildings. And that might not be something that you've built from the ground, it might be just a refashioning of an old part of the site. But the bit we probably haven't really aligned on is things like the correct surveillance mechanisms for this from an infection prevention control perspective, looking at the definition of an environmental outbreak. Does it need to have got into a patient, or are we going to take action if we just get some environmental samples positive? How should we use our laboratories to support investigating these risks? And what is it that we're actually trying to achieve when we've designed the correct interventions? Are we trying to clean the pipes out, or are we just trying to protect anything that's in the pipework or water getting into our patients and causing harm? So I'm just going to walk through now some of the approaches that you might want to take as an organisation to start to address this. So going back to the HTM, which is a very familiar water safety document for many of us, it's very clear that governance is concerned with how an organisation directs, manages and monitors activity, really focusing on compliance with the statutory requirements and legislative frameworks. And we absolutely have to do that to keep the building safe. And, that's a very well-rehearsed aspect of water safety. But it also does state, whilst ensuring the safety of patients, visitor and staff. And sometimes when you read the HTM, you almost read that that's about scalding risk, which obviously is an error event. We obviously must not scald our patients with hot water. But we need to recognise also that we can be completely compliant with HTMs and with other recommendations, and our patients might not be safe because we might be handling an outbreak or a concern related to water or wastewater. So to have the right leadership and governance balance across an organisation, you're going to need a very strong and confident clinical voice that sits alongside a very strong and confident engineering and estates voice. And I think you're bringing a lot of things together at this point, because you're bringing together traditional infection prevention and control. You're bringing together antimicrobial resistance and stewardship, which is going to impact the microbiome in your environment. And also you're going to be bringing the kind of estates and engineering leadership model that your organisation has. And these are subtly different across different sites. But I think this is a really good moment. All of us across England have been asked to write to our boards and present how we're going to tackle AMR. And I do think this is an infection prevention control risk, and that we need to not just talk about prescribing and counting antimicrobial use. We need to also talk about the prevention of spread of AMR into our environment and back out into our patients. And there's different ways of approaching things. We could create a whole new industry in terms of water safety, infection prevention and control. But actually the infrastructure that we have already can be adapted to include water safety, surveillance, monitoring and interventions quite nicely. So this is a sort of very brief summary of who might be working in your organisation to prevent infection, and some of the guidance documents that we use in the UK. Different people will use different ones, and obviously across the UK we'll have different IPC manuals, etc. But as we build a strategy as an organisation to be compliant to these things, we can weave in water safety measures. So, for instance, here in Leeds, we have a lot of cleaning audits, but we've popped in a couple of extra steps in the cleaning audit to make sure that our sinks are clutter-free, that they drain well, and that they're not splashing any equipment. And that's fed back to our clinical staff once we've done our facilities audits. Similarly, we might want to educate our medical leaders about the importance of prescribing and how that might impact the local microbiome, albeit we've got a lot of missing information in the stepwise nature of that. We know that there's some risk there. And we might want to talk to our nursing leaders about how they're using water in the wards and areas, and how they might inform us about how to do that more safely, given the knowledge that we know that many wastewater areas will be contaminated with pathogens that can infect patients. So I don't think this is about creating reams of new guidance documents, but I think it's about feathering through water safety interventions and knowledge into a lot of the work that we're doing brilliantly already. My slides have stopped moving on. There we go. The workhorse of water safety measures across the NHS has tended to be the water safety group. And this is a schematic on the left that's in the HTM, but it's quite a limited membership. And if we're going to be truly safe in terms of maintaining patient safety, we will need a clinical voice, looking at any infections that have turned up that could be related to the water systems. If there's a little cluster of Pseudomonas cases, or we've seen some pathogens that we wouldn't normally see in line infections like Pseudomonas, that needs to come back to the water safety group, and we need to have a strategy of how to deal with that information, investigate it and mitigate it, and understand when we're going to raise that as an incident or outbreak. So membership of the water safety group can be vastly broadened by bringing a lot of clinical teams into that. Some people do this and some people don't, but it's certainly hugely beneficial in terms of having the right conversation and making sure that we're both engineering competent and clinically competent at the same time. And different members of the water safety group will have quite different roles and responsibilities related to hygiene risks. So it's really good to have your laboratory staff along, because they will have expertise in the best way to sample the built environment, to process water samples, looking at SOPs for things that don't have maybe national standards, and seeing how we can support investigations of risks across the trust, hospital or care community, to investigate that from a laboratory point of view. We know our facilities teams, both our cleaners and catering teams, are really important, and they might have much more practical aspects to think about in terms of the mechanisms of how the organisation is getting cleaned, how water is being used, how it's being disposed of, and how that interacts with the clinical care that's given out on the wards. And so on and so forth. Everybody will have a different role and responsibility, and their expertise into their day job is really important in terms of evolving that into a slightly more water safe way of working. And our experience here in Leeds is it's really the interaction between these teams that makes the big difference. So, for instance, we know that slow draining sinks can become blocked sinks, and blocked sinks can eventually cause egress of water from the wastewater and drainage back into a clinical area, which we absolutely never would want. So we want a reporting system for slow draining sinks so we can nip the problem in the bud. And this is the reporting system, just very briefly, that we use. We make sure that the sink is identified and it's reported immediately to the estates team as a matter of urgency for somebody to come and do some remedial action. At that point, the sink is placed out of use with a piece of signage. You can see that, and that's possible to decontaminate for any IPC people on the call. And we make sure that the sink is unblocked in a way that does not contaminate the wider environment, which requires training for our estates and facilities team. When they've unblocked a sink, they take a photograph so we know what's blocked it or caused the slow drainage. And the photograph of the items down the sink is sent to the clinical team so they know what happened and what they can do differently to make sure it doesn't happen again. And the final step is that the signage is turned over to say that the sink is ready for cleaning, because we really worry about anything that's been down in the wastewater area coming into the clinical environment. So we wouldn't want a sink to go back into use until it's been formally cleaned by someone who's professionally trained to clean a sink in an effective way. And that's our facilities teams. But really that interaction between all those different individuals is really quite complex when you start to think about it. And we're certainly not the only ones thinking about it. There's wonderful teams across many areas who have done a lot of similar work. And this is a really nice demonstration from Mark Garvey's team in Birmingham about what we mean by splash risk. Everyone talks all the time about the splash zone, but this was a really nice piece of work published looking at 231 water outlets in intensive care. And what you can see there is the number of items that are in the splash zone of those water outlets on the right, and you can see the kind of extent of the splash zones on the left. So we know that for many sinks across a hospital, there will be items in the splash zone. And again, you're going to need a multidisciplinary approach to try and deal with that, because a lot of that might be to do with your storage areas, which might mean that somebody needs to go and put some shelves up or take some shelves down somewhere. Or it may be that you've got a misplaced sink that just needs to come out. But obviously, you've got to make sure that your teams on the wards can deliver safe care as you make those adaptations and changes. So it really is a multidisciplinary response. It's not just knowing about the splash zone, it's what you do next. There's been some really good systematic reviews just understanding where the AMR risk is. So where are those multi-resistant organisms in the water setting? We know that drains and drainage are a risk, but they can be on sink surfaces, they can be on taps themselves, showers and equipments, and obviously there's the toilets, the toilet bowls and the toilet brushes. And again, you know, we've sat in meetings here for quite a long time talking about the etiquette and the rotation of toilet brushes, which might not obviously sort of be the thing that you're trained to do in medical school, but it's really important when you're trying to make sure you don't spread pathogens around an organisation. And how do we have this multidisciplinary approach in both a reactive and a proactive way? Well, the best thing to do is to go out and look on the wards about the water hygiene risks that you're concerned about. And you can see the Brownie brothers here, they're obviously Leeds based, so I thought I'd put them in. And this is really about putting your water goggles on. So, you know, you're just for a moment going to have to forget about those hand hygiene audits and forget about the patient care. Hopefully someone else is doing that, and focus entirely on the built environment of your wards and specifically on water outlets. And we found this is a really effective way of just making lots of tweaks and changes to reduce items getting splashed, to identify low-use sinks that don't need to be there, that are not getting utilised, and to get around the areas of the wards where you're going to see a lot of water use. It might be in your dirty utility, it might be in your kitchen, and identify what we can do different. It's always a really good time also to talk to patients, staff and families about water hygiene and other aspects of the built environment in infection prevention and control, and just make sure we're optimising the environment to reduce the contamination from water and wastewater. And what we're really looking for is what you can see on the left there. That's Katie Sweeting, one of our matrons. It's a clutter-free area so that we're not seeing anything splashed in a bathroom and that it can be cleaned effectively. The sink in the middle there looked completely empty when we walked past it, but when you start to run the tap, you find it's slow draining and you can report that. So again, you know, don't always take what you see for granted. You need to kind of get stuck in there and see what's going on. And in the water safety rounds, you might also just identify risks that you're not comfortable with. So this on the right is a sink that's much too near a patient bed space. So you've either got to move the bed, which is actually what we did in this case because it was much too tight a space for an ITU bed, or you might decide to take the sink out. And that risk assessment has got to include people that are working on the ward. That's certainly not for IPC, estates or engineering to decide unilaterally. And we've been doing water safety rounds in Leeds for a number of years, mostly in our augmented care areas, but we do pop out to other areas from time to time and just go and have a real look around and see where the water risks are. But we've also started to do a lot of visiting friends and neighbours. So you can see Chris Settle here. We went up to the northeast to visit his trust. His team came down to visit our trust, and really just looking at all those opportunities to learn as a community of practice how we can move into a direction of being more water safe whilst we're waiting for those lovely big RCTs that tell us exactly what the right thing to do is, because at the moment we don't know. So we're just doing these very simple measures to reduce splash risk, improve drainage, take sinks out that are a risk to patients. And we've also looked at alternative care pathways. You can see Tracy Fletcher here in the centre. She's been a peer support across our organisation, but also outside it, looking about, you know, how to develop water safety practices in adult ITU, how you're going to wash patients, shave patients, how you're going to handle your ventilation systems, what systems seem to be safest from a water point of view, how you're going to dispose of items in that clinical setting. And again, this isn't about having a right and a wrong. It's about risk assessment, learning your patient group, learning your footprint and working through everything. And once you've done your water safety rounds, it's really important to go then back to where you're going to take action. That might be your water safety group, it might be your infection prevention and control team meetings, wherever it needs to be, so that whatever you pick up in your walk-arounds in terms of your risks, you prioritise them and you can put the steps in place. One of the things I get asked a lot is, what does water safe care mean? Why is it different from water free care? What does water light care? And you'll see these terms in many publications, and originally in Hughes Topman's publication, where he coined the term water-free care. And he's admitted to me himself that this wasn't necessarily an absolute truth, that it wasn't necessarily completely water-free. So this really brings us into the concept of training and education. We don't have a shared understanding of exactly what these terms mean. We've used the term water safe care in Leeds because we're not necessarily eradicating water use or even necessarily reducing it. We're just making sure that we're using water as safely as we possibly can. But others will feel differently, and I think it's certainly something that would be really nice to get more of a consensus approach on. We have an educational framework for infection prevention and control, and touching back to what I was saying earlier, I think it's really important to recognise that we are already training people in good infection prevention practices, and that includes the built environment and environmental IPC, and adding this new knowledge that we have around the risks of water and wastewater is just another step in terms of training and upskilling our staff. And I think it really does have to be local at the moment. We don't have confirmed national guidance. And I thought I would just bring out this example of why you do need to have local training and education around water. This was a survey that Laura Seeley did, and a few of us worked with her on it and published it, looking at the water provision to adult hemato-oncology patients having bone marrow transplant. And we spoke to a lot of centres providing this service, many of which were closely married to the water that they gave their patients, but sometimes it was bottled water, sometimes it was boiled, cooled water, sometimes it was filtered water, sometimes it was plain tap water, or sometimes it was from a bespoke outlet. So we don't have a consensus view in the JC guidance of how to give water safely to bone marrow transplant patients. So it is about working out that risk assessment in your own centre and making sure that everybody is doing the same thing and aware of the risk, because the one thing we don't want is somebody putting a jug in a sink in a contaminated kitchen area near a drain and then taking it off to a neutropenic patient. So we probably know more about what we don't want to do than absolutely having consensus on the right thing to do. And as we've developed training and education here in Leeds, and again, I know that many others have done that, there's some really good guidance in the Scottish National IPC manual. Videos are really useful for water safety because you can see, as well as hear, what the risks are and what the solutions are. We've got bespoke videos for patient groups. This is Manish, he's one of our haematology consultants, and he made a video with our estates, facilities and nursing staff for our adult hemato-oncology unit to educate our patients and their families. We found that for our facilities team, that actually face-to-face training is best. How do you clean a sink safely? How do you manage a shower safely? And doing that as a practical training task has worked better than necessarily an email or a remote learning piece. And just going back, we also have patient focused training as well, which has been really nice. So should we be rolling out water safe care everywhere, or should we just be doing it in response to risk? And I think that's a really important question for which we don't yet have an answer. So reactive work might relate to an outbreak of infection, often related to wastewater and contaminated sinks or showers. And you're absolutely going to want to work together in that multidisciplinary way to address the risks, understand them, and put interventions in place. And I'll come to that shortly. But it might be that somebody's come into your organisation with a really highly resistant strain of Klebsiella or Candidaris or something like that, that you really want to prevent it getting into your water and wastewater system. So you might have a reactive approach to protect your built environment so it doesn't stay as a legacy for the next patient. Or it may be that you're responding to environmental water sampling results that you're not happy with and you want to put some water safety measures in. So the reactive work often does start here with a water safety walk around where you go and look at the built environment, that you do some training and education, that you do some assessments, and then you create an action plan. In terms of proactive work, we probably do need to do some proactive work in augmented care now that we understand the risks from wastewater, and certainly areas where we care for vulnerable patients. I think the jury's really out there about why we're doing that and what it might achieve. Many of you will recognise this paper, which was from Hygiene, looking at intensive care units and comparing the healthcare associated infection rate for those patients that were in a room with a sink and those who were in a room without a sink. And I think it's really important to recognise that this was a German paper, and they will have a particular way of building buildings, a particular level of HCI that might not be mapped out across other countries. But in this instance, they found that being cared for in a room without a sink was beneficial, that there was a lower infection rate. But there have been some subsequent studies that potentially haven't supported this. So I think the jury is still out about that proactive work. And certainly most of us would find it extremely disruptive to go into an ITU that doesn't have any infection problems or environmental risks and go ripping out sinks out of side rooms. So I think that local expertise, that MDT working in risk assessment is really important as we start to digest and take on board some of the evidence that's coming through and translate it into our own hospitals. When we do respond to risk, we need to do it in a formulaic way so that we understand that we're taking everybody on the journey. Sinks and hand hygiene are a core part of infection prevention and control. We're very clear about people's requirement to follow the WHO hand hygiene guidance. And messing with the sinks or removing them is going to create challenge and concern in that space. So we need to absolutely be having the conversations with all members of teams out on the ward. If you think there's a risk in an area from either through an outbreak or from the environment, then mapping both clinical samples that are positive, like where the patient's been, and environmental positive samples on a physical map of the water, and I'll show you one in a moment, is really helpful to just get your eye into where those risks might be. Is it disseminated across a whole ward area, or is it focused in one corner or in a couple of side rooms? It's really useful then to also map the water pathways of the patient. So in what way do you use water on this ward? It will be very different in a neonatal unit where you're making lots of milk bottles, changing nappies, looking after parents. That will be a very different water pathway for something like an adult intensive care unit where you've got a load of very static, sleepy adult patients that you've got good control over what you're doing in terms of providing care, and the water safety kit might be a little bit different there. And once you've done your risk assessments and you've mapped your isolates, you might want to change clinical practice, or you might want to change the built environment, or you might want to do both. And you're going to need to do that in an MDT fashion. And it may be that in that stepwise process, you feel that you haven't got enough information, that you want to go out and do additional environmental or patient sampling, which we will always do in an outbreak response. This is an example of mapping patients, which is the red dots, and environmental isolates, the blue dots, and trying to understand what kind of picture you're building. This was an award from 2020. And again, I've shown these slides historically. And these are the sorts of mapping focus that you might want to look at: the clinical pathways, toileting, drinking water, food, drug preparation, sluices and waste disposal, and then the water locations we've already discussed as well. The clinical practice change is the most interesting and enjoyable part of my last few years of work, in the fact that for many teams, once you introduce the concept that wastewater, particularly in drainage, is a risk, a lot of the practice change sort of happens quite naturally. People just start to move things away from sinks, or report to you when they have a sink they don't really use or that's splashing a lot. People get quite responsive to things like sinks that are slow draining and make sure that actions are taken quite quickly. And they get really innovative about how they might want to care for patients differently. So those innovations are different in different sites. You can see here bottled water using for water, but you can also use patient warmed wipes, or it may be that you just want to move your sinks around a bit and you can see a corridor sink there that might just mean that it's not then splashing on someone. And this isn't just limited to nursing and medical care. This is absolutely about our estates and facilities team. You can see some covered trolleys here because the facilities team were concerned that the kitchens were too small to make sure you could absolutely be sure that nothing would get splashed. So they wanted to maintain crockery and cutlery in a covered trolley to make sure that splashing couldn't occur. And similarly, water outlets, understanding where the safe drinking water is, how we maintain that will be different depending on the layout of your hospital. Dirty utilities are really important in terms of clinical practice change. Sometimes people will store clean items in dirty utilities, and there might be a risk of either splashing from the tipping of the bowl or the item itself, or from splashing or regress from the water, from the macerators or slop hoppers or water outlets themselves. So looking in your dirty utilities, looking at how you work in them, looking at how you store things in them is really important. Ideally, no clean items should be there. And if you absolutely have to store clean items in a dirty area, then cupboards and cupboard doors can just help break the risk of splash. If you came on this call hoping to know what to put down your drain to get rid of the CPE, I'm really sorry to disappoint you. I was asked not to cover this in too much detail because I think it's a topic for a couple of the other webinar sessions. Just a moment to say really that people have obviously used heat, chemical, biological agents, UV light and replacement and other interventions to try and remove the risk at source in terms of P-traps, shower drains and bottle traps and waste traps. There are hundreds of publications on this. And my understanding is the fact that we do not yet have robust evidence to say that there's a preferred solution, although there's a lot of interesting data out there. So that's all I will say on that. And I think it's really important to think about our proactive work, not just being about going and modifying a built environment that already exists or a brand new hospital building, but there may be little tweaks and changes as areas get refurbished as well. And I've just put this slide up to remind me of that. And this is a really nice picture that one of our architects did to just show the little pink lines of how you would walk to a sink from where you go. The other reason I put this up is we've learned very closely here that hand hygiene matters a huge amount. You need to have a lot of conversations about that as you talk about sinks or sink removal, and you need to make sure it's safe. But doors actually matter a lot as well. If you are going to have a side room without a sink, you need to be able to get out of that, and that will depend on your door, how it swings, whether it's electric operated, etc. So doors and hand hygiene and sinks seem to come together for us. I'm just wrapping up now, the last few slides. So with your water goggles on, it may be that changes to the built environment can be quite subtle. So you can see here on the right, the sink is not draining very well. And it might be that the paper towel is loosening little bits of paper that are blocking the sink. And you can also see that there's a shelf on the back of the sink where people are storing items. So very subtle changes to the built environment to just improve our water safety might be to make sure you don't have big ledges, or you educate your staff not to use them to store things, and that you move your towel dispensers away from the sink so the paper isn't dropping and blocking up those sinks. Taking opportunities to remove sinks that are not well used, that are high risk, can be useful, or it might be that you do that in response to an outbreak. So you can see here a sink on the left, which was very near an intensive care bed and liable to splash into a patient that could have a tracheostomy or long lines. And that sink just came out because it wasn't required. There was an alternative sink and it was creating risks without much benefit. So I will just summarise now and stop sharing, but I just wanted to just really to just bring together some of the things that I've described and be interested to know if you think it's useful what we've talked about today, which is that I don't think we necessarily have all the answers to how to respond to hygiene risks, but I do think we need to have a structure and strategy of how we're going to work together with expertise and organisations to deal with those risks. Environmental infection prevention and control in hospitals particularly is incredibly important. We don't yet know really how impactful it is in care homes and outside the building, but it's certainly a big part of how in the future we're likely to control both healthcare associated infection and antimicrobial resistance. And there's lots of learning when we look back at the control of things like C. difficile infection to bring through to come back and review again and to think again. We know that antimicrobial resistant pathogens can develop, exist, be seeded into and persist in wastewater pipework. And it's really important that we recognise that risk, even if we don't have all of the answers, just so that we can start to work together to look at the solutions and look how those solutions might impact our clinical care teams out on the wards. Even though we know that contamination can occur, we are yet uncertain in terms of all the reading that I've done, what is the relative contribution of the route of transmission from water and wastewater to HCI. We don't know how many of the cases that we see in hospital are from this route, to my understanding. We don't necessarily have a brilliant understanding of the control measures, or as I say, exactly what they are trying to achieve. Are we trying to reduce gram-negative sepsis? Are we trying to reduce contamination or colonisation of patients by CPE? Are we trying to eradicate the pathogens from the pipework? But what I would support is to have an approach where you've got clear leadership and governance, education and training, that you're out and about on the wards looking at these things and having the conversations and just looking if there's already tweaks in clinical practice and your ward environment that might just help. So I'll take any questions and stop sharing and hope that was useful to you. Oh gosh, there's an awful lot of you on the call. So yeah, be kind with your questions. Yeah.
Jessica, thank you so much. That was just a fascinating insight and I learned an awful lot. I loved the story you shared about going to visit your neighbours and friends, you know, and how that shared learning is really valuable. And also referenced a couple of my kind of key water papers, The Splash Zone by Mark. Such an interesting, you know, paper about the proximity of equipment within that splash zone. We've got nearly 20 questions, so John and I are going to do our best to weed them out. Please use the upvote if you'd like to see a question asked. So I'll start with a question from Delith. Delith would like to know what you think the pros and cons of a waterless hospital environment are, please.
Well, that's a big question. Got a week. I think that's a really good question. I think my personal experience is that we've been working on improving water safety for a number of years. And I think the water-free aspect has mainly overtaken what were more simple and practical measures. So water is integral to how we care for patients in almost every corner of the hospital, and to remove it is very difficult. That's, you know, I mean, in Leeds, we've got 22,000 staff, about half of which are clinical. So that's re-educating and retraining how we go about our daily work for thousands and thousands of individuals. And at the moment, I'm not sure we've got the evidence that that's absolutely required. So if you have a contaminated built environment and a persistent stealthy outbreak, as described in those many papers of CPE, absolutely the balance of risk may be towards going very water light to control that risk. Do we have evidence now to say that we need to change the practice, expose everybody to aspergillus as we go and pull out a load of the built environment, you know, all of those things that come along with changing your built environment, moving patients that are very sick and poorly in very full hospitals? Do we have evidence to do that? I don't know. I think what's really interesting and what I have touched into a little bit is the new hospitals program in the UK, and I've sort of been spoken to them and they've been visited here. And that conversation, you know, if you do have a clean slate and you're going to build a brand new hospital, how water safe would you make it? And the conversations that we've had here have probably ended up a little bit hybrid in the fact that you probably don't need a sink in all your side rooms, but you probably might want it in one or two of them because you might still have C. diff norovirus patients or a new pathogen that turns up 2 or 3 years down the line that might mean that you need that. So I don't have the answers, but I can tell you that's where we kind of landed, is that there's a huge amount of retraining and education, which is a risk. There's a huge amount of risk from doing building works in existing estate. But given the opportunity to design something new, there's certainly a benefit of making it a lot more water safe than the current models and to reduce the number of sinks dramatically. So that's my opinion. I can't tell you it's right or wrong, but there you go.
Thanks, Jessica. It was a really excellent session. I enjoyed it and learned a lot and coming away feeling quite inspired, actually. So really, really nice. I think your response to that's really helpful. It's sort of iterative, proportionate, stepwise kind of approach rather than let's take all of the sinks out in all of our wards at the same time. Let's just look where our biggest risks are and kind of work step by step, really. Okay, can I pick up on a question from Kathy, which was similar to something I picked up? You said it almost in passing. You talked about professionally trained staff to clean a sink, which is a very simple statement, but actually there's quite a lot in there. We don't necessarily think of professional training required to clean a sink. I wonder if you could comment on that, and at the same time pick up Kathy's question, which was a similar question about the removal of blockages, as in practically speaking, what are the steps we would take and what are the requirements to make sure that's done as effectively and safely as it can be?
It's a really good question about professionally trained staff, and what I've actually missed off, I've realised, is my acknowledgement slides of the hundreds of people that I've learned from through this process. And one of the first people I learned them from was Suzanne Lee, who many of you will know and is a friend of mine. And she wrote something down that I really believe in the first kind of email I think that I had with her, is that our facilities staff, our cleaners, are experts and we need to listen to them and understand them and train them. And interestingly, our cleaning teams in Leeds are second to none, and they've actually just accredited a course which is an apprenticeship level 2 about how to clean in a water safe way. So it's a standard cleaning qualification, but in it is the Leeds way of cleaning in a water safe way. And that is about the routines for sinks and how you make sure you do that so you don't contaminate. So there is a huge amount of expertise in it, and it will probably be different in different trusts, and leaning in and learning from that expertise as an infection doctor I found really helpful. In terms of the assurance around that, you can do some really interesting things. So we've just picked up, you can do some virtual reality training of cleaning, which they're doing in Holland and Australia, and we're going to trial that here. So again, how do you know someone's competent to do that? Well, it may well be that you can do that by kind of assessments that are in a little virtual reality room around the back, and so that we've kind of got an insight into what individuals are doing. So yeah, it's not just about auditing. I think it's about training and respecting that expertise. Does that answer the question? I think there was a second part I might have missed.
No, that's great. Thank you. That's perfect. I think whether it's a sink or whether it's unblocking a drain, this idea of what are the protocols, it seems straightforward on face value, but actually when you look at it, and I've had this experience myself, when you actually write down an SOP for clearing a drain or unblocking a sink or cleaning a sink, actually there's a lot of opinion that suddenly comes to the fore.
Absolutely. And I think unblocking a drain is something that you need an SOP for and training for. And I'm not sure that that's standard across many hospitals. Otherwise you do. And I think one of the things we all worry about, don't we, is we put the interventions into the wastewater that we actually disseminate organisms that are actually sitting there quietly, not bothering anyone. So we need to be really careful around that.
Thanks, Jessica. You touched upon, the different options for treatment of organisms within drains and biofilms. And there's a question here from Rebecca about the use of biocides, and she specifically talks about hypochlorous acid, which is a biocide that I've heard a lot about in the last couple of years and its potential benefits. But just wondering if there's any evidence studies that you're aware of showing about control of biofilms from things like hypochlorous acid.
I'm pretty sure there's plenty of publications, some of which say that it's the answer and others which say it makes no difference at all. And again, this is what's so fascinating. And I thought the last webinar was so interesting, looking at the genomics of everything. So it may well be, it depends on your bugs, or depends on your sink, or is your pipework made of ceramic, metal, or plastic. So I think it's really difficult. I think we're looking for that solution, but it might be about what works in your setting, which I always think is a little bit like laboratory accreditation. It's how you handle sampling in your hands that you're accredited to, not just that you're following an SOP. It's got to produce results in your area. And I do wonder whether these interventions, biocides, you'll hear a lot of very passionate advocates for them, and also those that don't like them, but I'm not sure there's an absolute answer, and the literature supports that you get different results depending on the study that you've done.
Yeah, I think I tend to agree with you. I think you see studies which say it does work and it resolves everything. Maybe if I just can have a follow-on question. I completely agree about how the genomics is fascinating and can really unearth, what is there in terms of diversity. But I guess it's just whether or not that is practical and, real world. When do we actually think, well, we need to use genomics to see what's down the trap, or would we like to live in a world ideally where we could do it all the time and then we can dose the sinks appropriately? What do you think?
I think it's fascinating how genomics is revealing the secrets of the pathogens. I'm really enjoying everything that I'm reading at the moment. The conversations that they're having between the human pathogens and the plumbing pathogens and the shared genetic material. Having said that, I am so sad that I have been back and read everything that Florence Nightingale ever wrote. And she's very clear, it's about where you put the sink. So all the fancy sink types, the biocides, the genomics, it's just keeping it all well away from your patients that matters. And there's a little part of me that just feels we just need to keep all these sinks well away from our patients and not splashing on them. And that might be a more effective approach than a very constant, regular genomic service. But having said that, it depends on what your patient problem is. If you've got clinical infection, that's very different. You absolutely do want that genomic information. If you're seeing clinical infections, if you're just interested in what's in your pipes, I'm just not sure it's worth the money. But again, that's a very personal opinion. I don't know, John, what your thoughts are on that. You probably know more than I do.
Yeah, I mean, I can definitely foresee a future where genomics, and I mean, whole genome sequencing and metagenomics will play a big role in all that we do, and I'd include water hygiene in that to understand and to tease out which pathogens are significant and which are noise. But I think that's a little bit down the line. I think we're going to be focusing on patient sampling initially rather than going down the environmental route, because it's that much more complicated given the diversity of microbiology down there. We must move on because there's a few brilliant questions we've got to get through in the next 10 minutes. So really good and important question here from Kathy about implementing change. So often we identify risk areas, we identify mitigations that we know are going to be effective, but they're quite invasive and they require knocking holes in the hospital environment. So how do we go about implementing these mitigations in the busy modern healthcare setting?
I think the answer is the answer that really frustrates everybody, and it's about risk assessment. It's about how important the interventions are and how much disruption, money, operational pressure that you're willing to create to deal with the risk that you're facing. When I showed the slide about your Director of Infection Prevention Control and the board being aware of the risks of water and wastewater, I think this is incredibly important. So the operational team of your trust know that your trusts are often full. There is no spare capacity to close a ward to do building works. The financial director is going to be monitoring the purse strings, and there's no pot of money sitting there waiting for you to do some really big capital works. So you're really going to have to work at an exec level between the infection prevention and control director and those other individuals to find the balance and to get their support to do the works that you as an infection team feel are required. I'm a big fan of if there is a particular risk that you really do take it very seriously and you take it to that level, But then also just using that opportunistic moment if a ward is shut because of electrical works, and just go in and have a look at the sinks and see if any can be whipped out. So it's about that kind of double level, isn't it, of like creating the incident response where there is a clinical risk, but if there isn't much of a clinical risk, taking opportunistic moments to be as least disruptive as you can, to just constantly nudge your built environment into a safer setup. And that's the approach that we've tended to take here. But yeah, it is a big commitment to empty a ward, for instance, of patients, isn't it, in this day and age? We used to decant every ward every year, didn't we, to C. diff, but I don't know many people that still do that. Some do, but it's rare.
Fab. This is a really interesting question from Ijoma, talking about what the wider consequences of sink removal are, and how that might impact on drainage networks and flow patterns. I just wondered if you had, any insight that there are kind of any unintended consequences of sink removal.
Absolutely is the answer. And this is going back to your first question, John. This is why I love doing this work, because when you work, we have members of staff here, and I've met them in many other trusts as well, that have worked with a building for decades. They know their building. They know how to balance the system, keep the flow, get the temperature right. They know how to take those dead legs out or make those amendments whilst balancing the system. So it's an absolutely central part of the conversation. It usually happens at Water Safety Group, and I as a microbiologist usually learn tons when we have those conversations. So it's the right question. And it is very dependent on the age of the building. But what you really want is those engineers that know the building really well so that they can do that safely.
Okay, so we all want to have a really robust, proactive system of risk management around water hygiene that involves early intervention when we see things going off track. But which do you think are the most useful indicators that things are going wrong? When we could be looking at, for example, water sampling for microbiology, we could be looking at water temperature or flow monitoring, or perhaps we could be looking at more frontline ward level indicators around blockages, where we need point of use filters. Do you have a sense of which are the most useful early indicators that things are going wrong?
I think that's a really difficult question. I think one of the conversations I've had with many people, because I'm really curious about it, is what do you do when you have a positive water sample for Pseudomonas? Because I know it says in the HTM, remedial action, retest, get it negative, move on, but there's a lot more to it than that. Is there a patient sitting in the bed next to that tap? Have they ever had Pseudomonas? So that response to patient positivity and response to outlet positivity, with a marriage between clinical and engineering responses, I think is really interesting. And I think that, again, it's a risk assessment. It may be that a positive outlet is not that interesting clinically, or it may be that a clinical story is not that interesting from an engineering point of view because the person's had Pseudomonas for years. But until we start to lean into the early signs, like you say, and make a clinical and engineering joint assessment, I'm not sure I know the answer to that question. So we've started to do that here, but we've probably not been doing it in as robust a way for as long enough to really answer the question. And I haven't heard of anyone else that's really got that answer. But I'd be interested, Phil and John, if you've got experiences or opinions on that. But yeah, I think it's about learning a lot more about how we respond to these early positives and whether they've got clinical impact.
Well, I mean, I'm pretty excited about the prospects of continuous monitoring of water temperature and water flow. I think that could become the prime early indicator of system challenge. Because at the moment we're taking samples at such infrequent intervals around temperature management, temperature and microbiology. It's sometimes not helpful to the point of giving us false assurance. Whereas if we have that continuous flow of data, then I think we can get a much better understanding of the system as a whole.
Jessica, thank you so much. I'm sorry we didn't get to everybody's questions. We had so many of them, and I think it might be up there for a record attendance, but really well presented, loads of information, really informative, and lots of really kind comments in the chat. So a big thank you from IPC Partners. I'm just going to close with a couple of slides, which is going to tell you a little bit about a couple of things that we have going on. So if I can just cycle forward. Our next Insight webinar is on the 15th of April with Kerry Holden, and Kerry is going to be talking about addressing healthcare inequalities in IPC. If you've got the QR codes coming now that you might want to scan, which give you some info for it. So we look forward to welcoming Kerry on the 15th of April. You can view all of our journal clubs and insight webinars schedule here. This QR code will take you to the IPC Partners website, and you can see all of our schedule. John and I are really proud of the schedule that we've got running all the way to the summer, with some fantastic speakers. And also you can see the recording. There's a lot of people who have been asking about whether or not the slides will be available. We don't share slides, but we do share the recording, and that will be hosted on our IPC Partners YouTube channel. You can scan the QR code or either just search IPC Partners on YouTube. And finally, we've just got some messages from our partners. You can see here what's coming up from the IPS. This is a direct link to all the conferences, webinars and meetings that are going on that are being run by the Infection Prevention Society. So please do check out their website. And then finally from HIS are keen to talk about their special interest groups. There's some examples there of Spark and Building Safer Hospitals. So you can get access here through the QR code on the different special interest groups that are available from the Healthcare Infection Society. And really apt as well, I think, again, there were questions in the chat about training and education. There is a water and wastewater safety and healthcare course run by HIS. You can register for one that is being run in May of this year, so please do check that out as well. And also, if you'd like to become a member of HIS, you can do by going through the website or using that QR code and accessing various membership benefits from joining Healthcare Infection Society. So finally, last thing to do is just thank Jessica again. Thank you for everybody who attended. Thank you for all your engagement, and we hope to see you next time. Cheers. Bye.